Leah, can you hear? Hello, Leah, can you hear me?
Yes, ma'am. Audible.
Okay. So shall I start?
Ma'am, 2 minutes. 36 air.
Okay.
Ma'am, start here. Ma'am.
Okay, just a minute.
Okay.
Okay, so today is my last class on retina. One important topic is followed by one important topic. This is again a very small topic on central serous retinopathy. So what do you mean by the central serous chorioretinopathy? It occurs in young males. And in the picture, this is an OCT picture in which you can see this red line is a retinal pigment epithelium. And this part is the neurosensory retina. That is the inner 9 layers. So the retina has got 10 layers. And because of the developmental peculiarity, there is a potential space between the retinal pigment epithelium. So this area is the choroid. You can see the choroidal blood vessels. This is the retinal pigment epithelium. And this is the foveal depression. So in the foveal area, the neurosensory retina, that is the inner 9 layers, gets detached from the underlying retinal pigment epithelium. So it is actually a localized form of retinal detachment, and patient presents with a sudden onset of positive central scotoma and metamorphopsia. So what do you mean by a scotoma? Scotoma is an absence in the field of vision or an area which cannot be visualized by the patient. Central scotoma means the central area. Just like I showed you, yesterday the picture of a dry ARMD or dry macular degeneration in which the patient cannot see the central area. So any condition which involves the macula will produce a positive central scotoma. Positive means the patient can appreciate the field effect. Negative scotoma, there is another term which is called as a negative scotoma. And negative scotoma means patient cannot appreciate the field effect. We can only during field charting, we can get a field effect. The typical example of a negative scotoma is our normal blind spot. We have got a blind spot in our eye, which corresponds to the optic disc. So optic disc is an example of a negative scotoma. And all persons are having a scotoma in the eye that is corresponding to the optic nerve head or optic disc, which is a typical negative scotoma. Okay, so this is a central serous retinopathy. Patient presents with a sudden blurring of vision, positive scotoma, metamorphopsia. What do you mean by metamorphopsia? Metamorphopsia is nothing but there is a change in shape of the object. So if you look into a line, a straight line, it appears as a wavy. Okay. And another symptom of macular. So these are the macular symptoms of macular disease: micropsia, macropsia, metamorphopsia, and positive scotoma, central scotoma. Micropsia means when you look at an object, the image appears smaller than the object. That is the diminution in the size of the image compared to the object is called a micropsia. Macropsia is a number of cones stimulated in the macular region is less than the normal, and macropsia is a larger size of the image than the object. So if there is an edema in the macular region, sometimes there will be crowding of the cones. So instead of a particular area, suppose you think there are normally there are 5 cones to be stimulated by an object to produce the normal sized image. If it is instead of the normal 5 cones, 10 cones are stimulated, it produces macropsia, and the reverse with a micropsia. So this localized detachment of the sensory retina. The treatment is a self-limiting disease, and if the symptoms are persisting for quite long time, you have to treat with a laser photocoagulation. So this is the picture of it. You can see this is the black and white photo. You can see there is a detachment of the retina at the macular area corresponding to this. In this picture, you can see there is a localized detachment of the retina, and you can see there is a leaking in the coronal region. Now, I come to a very, very important topic, that is retinal detachment. You have heard about the retinal detachment during your clinical classes as a cause for a sudden loss of vision. A patient presenting. So what do you mean by retinal detachment? Is the retina, the whole retina is detached from the underlying coron, the layers of the cones of the eye, that is innermost layer is the retina, then comes the uveal tissue, and outermost is the sclera. So what do you mean by retinal detachment? In the previous slide, I explained that there is because of the developmental peculiarity, if you have gone through the development of the eye, the optic vesicle gets folded like this. So there is a, finally it develops into the retina like this. So there is a potential, the inner part produces the neurosensory retina and the outer one produces the retinal pigment epithelium. So there is a potential space. There is a potential space between the neurosensory retina and the outer pigment epithelium. So even though we are calling the retina has got 10 layers, actually it is 2 parts, the outer retinal pigment epithelium and the inner neurosensory retina. And because of this potential space, it has got a tendency, whenever there is an accumulation of the fluid between this, the chance of separation of the neurosensory retina from the underlying retinal pigment epithelium is very common. So that is what is called as a retinal detachment. So it is not the whole retina which is, whenever you say the retinal detachment, it is not the whole retina which is detaching from the underlying choroid. It is the neurosensory retina, that is the inner 9 layers are separating from the retinal pigment epithelium. There are 3 different types of retinal detachment. One is the most common one, that is a rhegmatogenous retinal detachment. In the previous classes, I have told you about several causes of tractional retinal detachment. Any condition which leads on to neovascularization of the retina later can lead on to fibrous tissue proliferation, which pulls the retina from the underlying, the neurosensory retina from the underlying. So that is a pull by the fibrous tissue. The neurosensory retina is pulled inside. That is called a tractional retinal detachment. But the primary retinal detachment or the rhegmatogenous retinal detachment, patient has no other secondary causes like neovascularization, diabetic retinopathy, or central retinal vein occlusion, or ROP. These are all causes of tractional retinal detachment. Proliferative diabetic retinopathy, central retinal vein occlusion, leading on to neovascularization, branch retinal vein occlusion, then Yale's disease, retinopathy of prematurity, everything can cause a secondary retinal detachment, which is a tractional type of retinal detachment. And another type of secondary retinal detachment is exudative retinal detachment. Exudative means there is formation of fluid. Fluid accumulates between the neurosensory retina and the retinal pigment epithelium because of some reasons. I explained that in the later stage. So rhegmatogenous retinal detachment is otherwise called as a primary retinal detachment, which is the most common cause for a retinal detachment. So these are other types of retinal detachment. Here you can see there is an exudative type of retinal detachment. You can see the whole retina is yellowish white in color because of a massive exudation, maybe from a choroidal hemorrhage, maybe from a choroidal melanoma with the fluid, then toxemias of pregnancy, angiomatosis, retina, everything can cause massive exudation into the from the choroid into the subretinal space, that is into the between the neurosensory retina and the retinal pigment epithelium. So these are the causes of exudative type of detachment, and traction I explained, for any cause that can lead on to proliferative retinopathy and new vessel formation like ROP and other diabetic retinopathy like that. Now I come to our main topic, that is a rhegmatogenous retinal detachment. So what do you mean by rhegma? Rhegma means a break in the retina. Break in the retina means a neurosensory retina develops a hole in the neurosensory retina. You just imagine the inner 9 layers, the whole retina develops a break or a tear. Tear means a piece of the retina is torn. And what happens is, in a normal person, even if a hole develops in the neurosensory retina, nothing will happen because the vitreous is jelly-like. Just like a gel, your vitreous is very much condensed. So nothing will happen even if a patient, normal person, develops a retinal hole or a break. But in some predisposing patients or in old persons, more than 50 years of age, or in young patients with some predisposing factors like high myopia, the vitreous becomes fluidic. So vitreous becomes, there is a syneresis of the vitreous in old age, and also an early liquefaction of the vitreous occurs in young myopic individuals. So when the vitreous becomes fluid, instead of a jelly-like substance, vitreous becomes fluid, what happens is, and when the hole develops or a tear develops in the retina, this fluid will seep through the neurosensory retinal hole into the subretinal space, leading on to separation of the neurosensory retina from the underlying retinal pigment epithelium. So that is what is happening in a rhegmatogenous retinal detachment. So rhegma means a break in the neurosensory retina. That is why it is called as a rhegmatogenous retinal detachment. So detachment of the retina that occurs secondary to a break formation. So what are the predisposing factors? Which lesions can lead on to development of rhegma? Rhegma means a break. So there are some peripheral retinal degenerations which are common in myopic individuals or in some family members. Even if they are not myopic, in some families, it can run the retinal detachment, and all these peripheral retinal degeneration occurs in some families. So this is a very important thing I explained in the first class, that is the importance of doing an indirect ophthalmoscopy with indentation. So when you use the indirect ophthalmoscopy with a condensing lens, you can see, even though the magnification is less compared to direct ophthalmoscope, you can see the entire retina well up to the ora serrata, and all these predisposing lesions for retinal detachment occurs in the periphery of the retina beyond the equator near the ora serrata. So that can be visible only by an indirect ophthalmoscopy. So a high myopic patient, more than 6 diopters, it is mandatory to do an indirect ophthalmoscopy with indentation to see the peripheral retina for all these degenerations. And if you see these degeneration, there are some situations you have to treat these lesions prophylactically with the laser photocoagulation. So if you see patient with a high myopia and lattice degeneration, you have to treat the surrounding area with a laser photocoagulation so that it will help to prevent occurring a catastrophe in the eye. So these are the predisposing factors that occurs in the periphery. Lattice degeneration, white without pressure means when you see an indirect ophthalmoscopy, the retinal periphery shows some white areas, that is called white without pressure. There is another condition called white with pressure. With pressure means when you indent the peripheral retina, at that area you can see white color. That is not a predisposing condition for retinal detachment. So other lesions include diffuse chorioretinal atrophy, focal pigment clumps, retinoschisis. Retinoschisis means splitting of the neurosensory retina. Again, neurosensory retina itself, the 9 layers is split in the middle compact layers. So, so this is the diagrammatic representation of fundus seen by an indirect ophthalmoscopy. You can see the optic disc is so small with an indirect ophthalmoscopy because the magnification with a 20 diopter condensing lens is only 3 times that as that of a normal fundus. So you can see the optic disc, the retinal blood vessels, you can see the macular region with the fovea, you can see the ora serrata. This is the area of the ora serrata. You can see the vortex veins, the area of the equator, that is the vortex veins. And the lesions occurs, the peripheral retinal degeneration occurs in this area, which is visible only by an indirect ophthalmoscopy. So rhegma means a break or a discontinuity in the neurosensory retina, which is the most common type of retinal detachment due to retinal hole formation. Breaks in the retina may be retinal holes, tears, or dialysis. Dialysis means separation of the retina from the ora serrata, just like iridodialysis. So this is the pathophysiology. I already explained you. There is a break formation first that is occurring. The vitreous is fluidic in patients, senile patients, and also in postoperative patients. If the patient underwent cataract surgery or aphakia or pseudophakia or trauma, all these can lead on to, or uveitis, all these can lead on to fluidic vitreous and also high myopia. And in senile patients, that is after 50 years, the posterior vitreous is detached from the underlying neurosensory retina, and this because of the fluidic vitreous and the PVD, that is posterior vitreous detachment, the vitreous is attached to some areas, especially in this predisposing areas and also in subnormal areas. This will pull the retina, leading on to, just like a pulling, a small tear is formed in the retina and leads on to Rhegmatogenous type of retinal detachment. So you can see this is a diagrammatic representation. This is a diagrammatic representation of a rhegmatogenous retinal detachment. You can see the optic disc. You can see the normal pale pink color of the normal retina with the normal retinal blood vessels. You can see this is the ora serrata. And in this area, you can see the retina, instead of the normal pale pink color, you can see the retina is corrugated with a grayish white appearance. And you can see there is a small tear in the detached part of the retina. And this tear is responsible for allowing or seeping the fluid vitreous through the neurosensory retina, into the potential space between the retinal pigment epithelia. And here you can see this is a corresponding patient's own fundus. You can see there is a break in. Can you see? So this is the diagrammatic representation, and this is yeah, okay. So this is the retinal break that led on to detachment of the retina from the periphery. And here also you can see, you cannot see break in this area because it is not visible well up to the periphery. The retinal break occurred beyond this visible area. So that is why another picture which shows a huge break in the retina leading on to retinal detachment. You can see this is the optic disc. Up to this area, the retina is detached. You can see lines here. And this is the normal area of the retina. So these are all things I have already mentioned. Predisposing factors, myopia with the peripheral retinal degeneration. And already I explained the peripheral retinal degeneration, that is the lattice degeneration, white without pressure, diffuse chorioretinal atrophy, pigment clumps. And any patient who underwent cataract surgery or any surgery, aphakia or pseudophakia, the vitreous becomes fluidic. Family history of RD, retinal detachment, is again a predisposing factor. Trauma, I explained trauma again leading on to early vitreous degeneration and inflammation, that is patients with a chronic uveitis. Again, even if the patient normally vitreous becomes fluidic after 50 years of age, but in these situations, that is in trauma, in chronic uveitis, in myopia, the vitreous becomes fluidic before 50 years of age. Okay, understand? So what are the clinical features? How the patient presents in the OP? So usually we see patients who complains of sudden loss of vision in the affected eye, as if a curtain falling, sudden painless loss of vision. And usually patient says as if a curtain falling in front of the eye. That is a field effect. So that is typically a field effect that occurs usually commonly in myopic individuals. And I have written the F in yellow color. That is the 3 Fs of rhegmatogenous retinal detachment. The symptoms of 3 Fs of retinal detachment. That is the premonitory symptoms. Before sudden loss of vision, patient may have, because of the retinal tear formation, patient may have some bleeding into the vitreous cavity, which patient appreciates. The small bleeding, patient vitreous hemorrhage, patient feel it as a floaters. So appearance of floaters. Then the retina is pulled. I told you there is a break formation, and when you move the eye, this break will pull the neurosensory retina and irritate the retinal photoreceptors, and this irritation of the photoreceptors patient feel as photopsia, otherwise called as a flashes of light. So that is 1F. Because of the tear and irritation during movements of the eye, the neurosensory epithelium or the photoreceptors are irritated, leading on to the perception of photopsia or flashes of light. Then, because of the small pigments or hemorrhage into the vitreous cavity, patient appreciates it as a floaters. And the third is a field effect, that is as if a curtain falling in front of the eye and later becomes a complete loss of vision. Okay, so it is a cause for painless sudden loss of vision, retinal detachment that involves the macula. So how will you diagnose? I already showed you the picture of retinal detachment, where it is mandatory to do, and in any patient, especially a myopic individual or in predisposing patients, that is a pseudophakic or a phakic recurrent inflammation, family history, who complains of these symptoms, that is flashes or floaters with some field effect, it is mandatory to do indirect. So diagnostic confirmation of the diagnosis is by indirect ophthalmoscopy with the indentation to see the complete area after complete dilatation or complete dilatation of the pupil with a tropicacil plus, that is tropicamide plus phenylephrine with a complete mydriasis. So indirect ophthalmoscopy with the indentation to see the extreme periphery of the retina, and the detached retina, as I shown you, it appears as a white or gray in color. White or gray in color. So that is the clinical appearance. And in some situation, it may be very difficult to see it. In that situation, you have to do a B scan. Okay, sorry. So how will you see the fundus with indirect? What is the appearance? I told you the color of the retina instead of the norm. Actually, retina is transparent. The retina is transparent. What is the normal pale pink color is the normal choroidal blood vessels are seen. Choroid is a vascular. In the uveal tract is the otherwise called as the vascular coat of the eye. So through the transparent retina, we are seeing the underlying choroidal vasculature as a pale pink color or a red color. Okay. So when the neurosensory retina is detached from the underlying retinal pigment epithelium and choroid, that red color is lost. So that is why it appears as a. So this is the normal color of the retina, and this color is due to retina is a transparent membrane, and through which the choroid is seen as a red color. I mean, the choroidal blood vessel is seen, we are seeing it as a red color. But if it is detached from the underlying retinal pigment epithelium or choroid, the normal color is lost and it becomes white in color, and the transparency also is lost. That is the appearance. It is written as a gray or white in color. And this detached retina will move freely if it is a fresh retinal detachment, oscillates on movement. So if you ask the patient to move the eye, this detached retina moves along with the movement of the eye, and the normal appearance of the retinal blood vessels are also lost, and it appears black in color with the no light reflex within the walls of the retinal blood vessels, and the normal choroidal pattern is also not visible. If the whole retina is detached, then it appears just like it is attached to the optic disc. It becomes a funnel-shaped retinal detachment. So I explained something in long-standing retinal detachment that can lead on to complicated cataract decrease, and this is not important for you. Okay. So retinal detachment, patient presents with high myopia and other predisposing factors, patient presents with a sudden painless loss of vision. I explained other causes of sudden painless loss of vision in the previous class. All retinal, majority of the retinal diseases, patient presents with a sudden loss of vision, just like ischemic central retinal vein occlusion or other central retinal vein occlusion, central retinal artery occlusion, ischemic optic neuropathy, that is not a retinal, that is an optic, and patients with the papillitis, all presents with a sudden loss of painless loss of vision. So retinal detachment involving the macula also. So what is the management? So how will you manage this patient? And whenever the management is asked, in community medicine, we teach that prophylaxis is always better than, always very, very important. So treatment. So whenever you see a patient with a high myopia, it is mandatory, again and again I am telling it is mandatory to do a indirect ophthalmoscopy after complete mydriasis to see well up to the periphery. And if you see any predisposing lesions, especially in patients who are susceptible, like family history, high myopia, treat that lesions prophylactically. And if the patient already developed a retinal detachment, then the treatment of that eye includes surgical treatment, and you have to see the other eye for any predisposing factors or any breaks, and you have to treat prophylactically the opposite eye in which there is a prophylactic peripheral retinal degeneration. Prophylactic treatment is just apply laser around the particular lesion, or in some situation you can apply CRAO also, cryotherapy also. All either laser or cryotherapy for all breaks or predisposing factors, and needs a lifelong follow. So again, indirect ophthalmoscopy with a scleral indentation after full mydriasis, and you have to see all the see all the breaks, because you have to locate all the breaks and treat all the breaks. And surgical management of the retinal detachment is also after proper localization. Sometimes there may be multiple tears in the retina, not only a single break. The previous picture I showed you only a single break which is responsible for that part of the retinal detachment. And in some situations there are so many breaks, so you have to identify all the breaks and treat it. So how will you treat the retinal detachment? There are two types. So what is our primary aim is to attach the neurosensory retina to the underlying retinal pigment epithelium, to the underlying retinal pigment. So what is happening here is there is a fluid in between this two space with a retinal hole. Okay, so there is a hole in the neurosensory retina, and through which the fluidic vitreous entered into the potential space between the neurosensory retina and the retinal pigment epithelium. So our aim is to attach these two, remove the fluid from the space, and make adhesion between these two. Okay, so what we have to do is we have to drain the subretinal fluid, or SRF is a subretinal fluid, drainage of the subretinal fluid, so that they are opposed. The neurosensory retina is opposed to the underlying retinal pigment epithelium. Okay, so this apposition can be done either from an external source or from internally. Okay, either internally you can press the neurosensory retina after removal of the subretinal fluid. You can force the neurosensory retina over to the underlying retinal pigment epithelium, or after draining subretinal fluid, you can compress from outside in, so that the retinal pigment epithelium is opposed to the neurosensory retina. So how we can do this? So first you have to drain the subretinal fluid, and external tamponade, it is called as a tamponade. So external tamponade means you have to apply some scleral buckle, that is we use some silicone sponge or silicone, just like a buckle or belt. We are applying silicone sponge or silicone tire, like that is a band or band of silicone over the sclera, and we tie that sclera after tie that silicone band, so that the sclera, choroid, and the retinal pigment epithelium are opposed over to the neurosensory retina. And you have to apply CRAO around the retinal break. Otherwise, again, the same thing can happen. And if it is not possible, in some situations, CRAO we can apply only from externally, that is only in the extreme peripheral lesions only, or localized retinal detachment. If it is not possible, what we have to do is we have to go internally, that is through the pars plana we do vitrectomy, and some expansile gases are air or expansile gases are injected into the vitreous cavity so that these gases will expand and push the neurosensory retina over to the retinal pigment epithelium. So that is the basics of retinal detachment surgery. One is that is called a tamponade. Tamponade can be either an external tamponade after draining the subretinal fluid and applying cryotherapy with an external tamponade, or an internal tamponade using expansile gases, and you have to do laser. Okay. So ensure chorioretinal apposition by either or both of external tamponade using silicone buckle, sponge, tire, or encircling band, or an internal tamponade using air or gases such as expansile gases such as sulfur hexafluoride or perfluoropropane C3F8, or liquids such as silicone oil. Okay. So this is the treatment of primary or rhegmatogenous retinal detachment. And if the patient develops a proliferative vitreoretinopathy, that situation you have to use a silicone oil. So the confirmation of the diagnosis of rhegmatogenous retinal detachment is, one is an indirect ophthalmoscopy with a complete mydriasis using a +20 diopter condensing lens. See the extreme periphery, localize all the breaks, and then decide upon what treatment, either an external tamponade after drainage of the subretinal fluid and along with the cryotherapy, or an internal tamponade using expansile gases and laser photocoagulation of all the breaks to prevent recurrence. Okay. And in some situation, we cannot see the retinal because the whole retina may be detached. In that situation, B scan, or if the patient has got a total cataract or very poor view because of the vitreous hemorrhage, so the investigation is B scan, that is ultrasound B scan of the orbit, eye. So this is again, it is not that important for an undergraduate level. That is a complication of retinal detachment surgery. Retinal detachment, even if you do surgery, the detachment may persist, or the patient may develop a macular scar or proliferative vitreoretinal retinopathy, recurrent retinal detachment, and during scleral buckle, that is, I told you, we are applying pressure from external. In that situation, we are disinserting the muscles. We are disinserting the recti muscles, and underneath that, we are creating a small partial, just like our cataract surgery, we are doing some partial thickness scleral flap into which we are putting this silicone band. Okay, so whenever we disinsert the extraocular muscle, that can lead on to anterior segment ischemia. So that is about the retinal detachment. I think I have understood about the retinal detachment. Now, only very few topics remaining. That is opacities in the vitreous, not for that important for an undergraduate, but for completion's sake, I am telling asteroid hyalosis, which occurs in elderly patients with a history of diabetes. And the treatment is usually doesn't require any treatment. If the patient complains of defective vision, vitrectomy is indicated. Another opacity in the vitreous is a synchisis scintillans. This occurs in a damaged eye. The other one in diabetic with a hypercholesterolemia. And last topic is vitreous haemorrhage. Vitreous haemorrhage, you can see this is the B scan picture, and this is the fundus is very hazily seen because of the vitreous haemorrhage. You can see the disc is here, you can see the blood vessels. So this is the vitreous cavity which is filled with the hyperechoic material. That is a fine hyperechoic material, which is the vitreous haemorrhage. You can see this area is the optic disc. So vitreous haemorrhage may be either pre-retinal, intravitreal, or both. Pre-retinal means just in front of the retina, between the hyaloid and the retina, or it can be intragel, that is within the vitreous cavity. So indirect ophthalmoscopy again is mandatory. So I told you sometimes the patient can present retinal detachment, can present with the vitreous hemorrhage. So in all cases, you have to see the breaks in the retina by doing indirect ophthalmoscopy. And if the media is not clear because of the vitreous hemorrhage, you have to see with the B scan. So this is the picture of a B scan. Here you can see only the vitreous hemorrhage. If the retina is detached, you can see along with that, there is a membranous echo, which I showed you in the first class. So the causes of vitreous hemorrhage include, vitreous hemorrhage is another cause for sudden loss of vision. Sudden loss of vision. The causes of vitreous hemorrhage, and this can be asked as a short note. Vitreous hemorrhage can be asked as a short note. So vitreous hemorrhage clinical feature is patient presents with a sudden loss of vision, and usually on external examination, the visual acuity may be ranging from 6/9 to very poor visual acuity, and normally, usually, there will not be any relative afferent pupillary defect. If there is an underlying retinal detachment, extensive retinal detachment, then only the patient will have a relative afferent pupillary defect. The causes include proliferative diabetic retinopathy, retinal tears. I told you the retinal tears patients present with the premonitory symptoms of flashes and floaters. Posterior vitreous detachment with vitreous traction, venous occlusions with the neovascularization of the retina and bleeding. Peripheral retinal neovascularization causes other causes like Eales disease, sickle cell retinopathy. And trauma is the commonest cause for vitreous hemorrhage in young patients, blunt trauma especially. So what is the treatment of vitreous hemorrhage? If the patient presents with a vitreous hemorrhage, you have to, if the media is not clear, you have to do a B scan. If the media is not that much affected, you have to do an indirect ophthalmoscopy to visualize the periphery and to treat the prophylactically the retinal breaks. If nothing is there, only posterior vitreous detachment leading on to vitreous hemorrhage, you have to wait and see the patient, follow pace needed. And immediately you can ask the patient to keep the head elevated so that the whole blood is not gravitated into the macular area. So whenever we lie down in the supine position, the whole blood can accumulate in the foveal area because of the macular area, because of the anatomical configuration. The fovea is just like a depressed area, and when you lie down in the supine position, that blood can collect in that area, and blood is always an irritant, so that the retinal, if it remains in the macular area, the photoreceptors can get damaged. So that is why we ask the patient to keep the head elevated so that the blood gravitates down. Okay. If it is not clearing in 2 to 3 months, we have to do vitrectomy. So that is the end of the class. I will show you some MCQs which will be beneficial for your entrance examination from the retina topic. So the earliest sign in diabetic retinopathy is microaneurysms. Okay, normal AV ratio 2:3. CSME is clinically significant macular edema, is best diagnosed by optical coherence tomography, or macular edema is best diagnosed by optical coherence tomography. All are used for retinal photocoagulation except. So these are the names of lasers used in ophthalmology. You can just note down, that is diode laser, excimer laser, argon laser, double frequency YAG laser, or green laser. So except this B, that is excimer laser, which is used for corneal LASIK procedures. Excimer is used for LASIK procedures. All the other lasers are used for retinal photocoagulation. Commonest cause for visual impairment in type 2 diabetes is diabetic maculopathy. Commonest cause for central retinal artery occlusion is atherosclerosis. Causes of tubular vision. Again, this is very important for one word answer. Causes, I mentioned retinitis pigmentosa, which produces retained central tubular vision, advanced primary open angle glaucoma, which produces temporal tubular island of vision, central retinal artery occlusion. In the first class, I explained you regarding a sparing. I showed you a picture of cilioretinal artery with a sparing of the macular region leading on to central tubular vision. And the fourth one is a central retinal vein occlusion, which will not produce tubular vision. The first three causes are causes of tubular vision, except central retinal vein occlusion. CFAN neovascularization is seen in sickle cell retinopathy. Leopard skin appearance. It is a peculiar appearance of infiltration of the retina, which is seen, not retina, because of the choroidal infiltration. The retina, you can see the patches of pigmentation that is seen in leukemia. Leopard skin appearance of the fundus is seen in leukemia because of the infiltration of the choroid. Size of the fovea is 0.35. Most common cause for irreversible visual loss more than 50 years of age is age-related macular degeneration. Choroidal vasculature is best seen using indocyanine green angiogram. Indocyanine green angiogram. Fuchs spot in the retina is seen with in the refractive error, high myopia. Foster Fuchs. It is otherwise called as a Foster Fuchs spot, seen in the macular region because in patients with a high myopia. Most severe form of retinitis pigmentosa is seen with an X-linked inheritance, X-linked recessive. Okay, so that is the end of my class. 4 classes are over, and I think only few classes are remaining. That is injuries. എത്ര ക്ലാസ് ഉണ്ട് എനിലിയ നിങ്ങൾക്ക്?
Injuries to the eye മാത്രമേ ഉള്ളൂ. ബാക്കിയെല്ലാം
അത് മനോജാണ് എടുക്കുന്നത്. മനോജ് സാറിനെ കോൺടാക്ട് ചെയ്താൽ മതി. Okay, so my class is over by today. You can send me the attendance. And any doubt in the retina, you can ask now. Anybody can ask. I'm discussing with Leah only because I cannot, easy for to. Any doubt, anybody? If there is no doubt, I'll stop sharing. Okay.
Okay. Thank you.
Okay, thank you. Bye.